If volume is not normal, then it goes in favor of dysphonia. If there any volume now is normal, and if you have any local problems, first thing they need to be correct. Something like dentures, some local infection in the mouth needs to be corrected. Then if his rhythm is normal or not. If the rhythm is not normal and he speaks like a drunken state, then it goes in favor of cerebellar dysarthria. Next question is, his speech is not slurred, but his speech is, whether his speech is monotonous or not. It means that there won't be any ups and downs in the speech that usually happen in the extrapyramidal symptoms like extrapyramidal speeches like Parkinsonism. If the speech is not monotonous, but he needs to put more effort, you need to put more pressing of the words, then it goes in for a spastic dysarthria. Next, coming to if the rhythm is normal, but he has a nasal tone to the speech, then it usually goes in favor of palatal fallacy. If he can, then if the speech is not nasal, then if can he utter the word any word letters causing word T and S. If it is lost, then it goes. If it goes lost, then it goes in favor of facial or tongue fallacy. If they can use the letters, if he can use letters T and S, but he can't use letters of B and P, then it's called goes in favor of patka. The pa comes to lip, ta comes to tongue, and ka goes to the larynx. If you ask the patient to utter this word, then you will come to know where is the legend is. To summarize higher mental function, the frontal lobe, usually people will have apathy and disinhibition. It's called social disinhibition. Along with that, they will have contralateral hemiplegia and motor aphasia. The temporal lobe, there they can be loss of memory. Along with that, they have sensory aphasia. And comes to the parietal lobe, they will the loss of the calculation and spatial orientation will be there. Along with that, they can have apraxia, umnanopus, immunopia. Coming to the occipital lobe, usually they will have an visual loss. So coming to the motor system, it will be examined in the following 5 headings. One is bulk, tone, power, reflexes, coordination, and gait. So to summarize how we approach the motor weakness is, first is generalized weakness, that is limbs and cranial nerves. The diffuse disease of the involving the nerve, they will very well in the morning. At the end of the day, they will feel fatigue and weakness. And muscle, it will mean uniform throughout the day, something like Duchenne muscle dystrophy. Usually along with they will have a pseudohypertrophy. Coming to the, if the weakness is there in all the four limbs, it can be any of these following. It is upper motor neuron. It is like on the spinal cord, particularly in the cervical and above. In the CNS, the only possibility of having all the four limb involvement, usually in the brainstem lesion, that is bilateral stroke. Any midline lesion, like involving the sagittal sinus thrombosis, can lead to the upper motor quadriparesis. Coming to the lower motor neuron, it can happen usually in the peripheral neuropathy like Guillain-Barré syndrome or polyradiculopathy can be there. And of course, in the muscle like Duchenne muscle dystrophy, there will be weakness of all the four limbs. Coming to the unilateral leg weakness, it usually happens in the upper motor neuron. Usually, lesion will be there in the brainstem and in the cortex. How to distinguish between these two is, if there is a ipsilateral cranial nerve involvement and contralateral hemiparesis, usually goes in favor of brainstem. And if along with hemiparesis, if has a higher mental function involvement like speech and involvement is there, it usually goes in favor of internal capsule and cortex involvement. Coming to the weakness of both the legs, so it can happen both in upper motor neuron and in the lower motor neuron. Upper motor neuron can only be explained by spinal cord lesion up to lumbar, sacral, and even up to the thoracic. Anything below C8. Coming to a single limb, this upper motor neuron usually happen very rarely. You see, it can be explained. Usually, the lesion will be there in the coronary radiata where fibers will be wide. Coming to the lower motor neuron, it can be single nerve, it is mononeuropathy or radiculopathy. Coming to the patchy weakness, it's usually in the upper motor, it happens because of the multiple CNS lesions. Lower motor neuron is happens because of the polyradiculopathy and mononeuritis multiplex. And variable weakness usually seen in myasthenia gravis, can it be functional also. So to summarize, let's first ask question: is there a weakness of all the four limbs? Yes. If it is, whether it is upper motor neuron or checking the plantar. If it is yes, the lesion has to be spinal cord and above. And If there is spinal cord involvement is there, usually you will have sensory signs. Next question is upper motor pattern is not there, the proximal is more than distal, then think of myopathy, and in myopathy there won't be any sensory loss. If the distal is more than proximal, think of neuropathy. Next, coming to there is no weakness of all the four limbs. There is a weakness in both the legs. Then it is goes in favor of paraplegia. If it is upper motor, it's usually not, it has to be invariably it will be there in the spinal cord usually. If it is not there, then again ask a question whether it is proximal distal. Again divide whether it is neuropathy or myopathy based on the distribution of the weakness. If the weakness is in the both the limbs, and usually if it has a sensory weakness, goes in favor of spinal cord. If there is a unilateral arm and leg weakness is present, usually lesion will be there in the brainstem and in the cerebral hemisphere. How to distinguish? As already told, like there will be involvement of ipsilateral cranial in brainstem. Thus, so if it is single limb involvement, then ask a question: is it a single root? Then it goes sort of radiculopathy. Or if there is no radicular pain, then this question comes: it can be a single nerve, that is called mononeuropathy. Then, if there is no single limb involvement but patchy weakness, but multiple nerves are involved, then think of mononeuritis multiplex. If there is a variable weakness with fatigue, that is in the morning you will be fine, the end of the day you will feel fatigue and weak, it goes in favor of myasthenic gravis, particularly in the ocular muscles. Then if there is no variable weakness present and fatigue is not there, usually it goes in favor of functional. So how to distinguish UMN and LMN lesion? On inspection, usually upper motor neuron, there will be no wasting, but it can be happen only in the long-standing UMN lesions. Usually the wasting and fasciculations are usually seen in LMN lesion. The tone is increased with clonus in the UMN lesion, and in the lower motor neuron, tone is normal or decreased. The weakness preferably affecting the extensors and flex in the upper limb and flexors in the leg is goes in favor of pyramidal weakness. And the group of muscles will be affected in the UMN lesions, whereas in lower limb it is individual muscles will be affected, and the weakness will be distributed along the nerve. And coming to the deep tendon reflexes, they are usually brisk in the UMN lesion, and they will be low or absent in LMN lesion. Now, of course, the D classical sign is plantar response. If it is extensor, the thumb is upgoing. It usually goes, fixes the lesion, spinal cord, and above it has to be an UMN. There is no other possibility. If it is lower motor neuron, it usually will be flexor. So this is attitude of the limb. Usually in patient with hemiplegia, the upper limb will be, there will be adduction at shoulder, flexion at elbow, semi-pronated, and tucked thumb into the palm. And in the lower limb, it will be extended at hip, knee, and external rotated at hip, and foot inverted, and there will be plantar flexion. So this is how the hemiplegic gait will look like. There will be a circumduction gait. This is how the Ebb's policy, the adduction and medial rotation at shoulder, extension at the elbow joint, and promotion at radial nerve joint usually goes in favor of Ebb's policy C5, C6, usually happens during birth. So examination of the muscle bulk nutrition can be done by both inspection as well as by measurements. The wasting is considered positive if there is a 1 centimeter reduction on the dominant extremity, or if it is more than 2 centimeter in the non-dominant extremity. So usually for the hand muscles, inspection is advocate where the eminence like prominence of the thenar, apothenar will be lost. Whereas other areas usually you need to measure, particularly for upper limb and lower limb. Usually from a fixed bony point, the measurement is taken as 10 centimeter below the olecranon for the forearm, 10 centimeter above for the arm, it is medial epicondyle, 80 centimeter above the patella for lower limb, that is leg, and 10 centimeter, 10 centimeter above the patella is taken for the thighs, and 80 centimeter below the tibial tuberosity. From there, you have to measure the circumference of the calf muscle to compare the is there any wasting is there or not. So this is how it is done. So you have to fix a point 10 centimeter below the olecranon and measure that circumference of the muscle in the forearm. So coming to the hypertrophy and pseudohypertrophy. True hypertrophy is where there is a true increase in the muscle fibers. It usually happens only because of exercise. So to maintain the good strength or muscle mass, so exercise is really important. The studies say that those who after the 40 years and those who don't exercise, they will lose around 3 to 5% of the muscle mass every year. So pseudohypertrophy, the muscle looks bulky, but it's because of the accumulation of the fatty tissue. It usually happens in muscular dystrophies and also endocrinal diseases like hypothyroidisms. So coming to the muscle wasting, it can be three varieties. One is generalized wasting, where entire body is affected. It usually happens in malignancy, TB, thyrotoxicosis, and of course AIDS. Coming to the where the proximal wasting is usually seen in motor neuron disease, inflammatory myopathy, and axillary neuropathy, and muscular facioscapulohumeral dystrophy involving the muscles of scapula and humerus. Distal wasting is usually seen in neuropathies, particularly like anterior arm cell, syringomyelia, arthritis, and diffuse atrophy. Coming to the muscle tone, what is tone? Tone is nothing but a resistance offered on moving a muscles across the joint passively. So, example in the upper limb tested on the wrist and elbow joint, and in the lower limb tested in the knee and ankle. Ask the patient to lie down supine. If you roll down like this, if you feel resistance more, it is usually it goes in favor of hypertonia. And ask the passively you flex around the knee joint. If you feel that resistance is more, it usually goes in favor of hypertonia. Another option is in the lower limb, you flex and keep the flex at knee joint and ask the try to keep the limb like that. If the patient has hypertonia, usually limb will fall. And in the upper limb Oliver test is you move across at the elbow joint. If you feel more resistance, it usually goes in favor of hypertonia. If you feel flabby, it goes in favor of hypertonia. Another option you have is you ask the limb, lift the limb and drop it down. If it falls freely, usually it goes in favor of hypertonia. So again, coming to the in the hypertonia, we have two things. One is spasticity and rigidity. The spasticity usually goes in favor of predominant, that is cortex, and rigidity goes usually in favor of extrapyramidal system like basal ganglia, usually seen in Parkinsonism. So the spasticity is called clasp knife, just like how you feel the resistance like while locking and unlocking in a seizure knife. Usually you feel the resistance, at some time the resistance will give away. That is usually happens in clasp knife spasticity, usually goes in favor of pyramidal. Rigidity, that where the resistance is uniform throughout the range of motion is usually goes in favor of extrapyramidal symptom like Parkinsonism. How to distinguish between is, if in the spasticity, since it is a pyramidal involvement, plantar response will be extensor, and rigidity, in case of rigidity, it will be usually it will be flexor, and it can also have a tremors and slowness of the movement. And in the spasticity, you will have an hyperreflexion, which will not be there in rigidity. Coming to the hypertonia, as I explained, it is usually there any lesion from the anterior constel till the muscle. Uh, so other causes of hypertonia other than pyramidal involvement is tetanus, tetany, and stitching poisoning, and the tonic phase of seizure. And in the psychiatric illness, usually it happens in schizophrenia. Coming to the muscle power, so you have five gradings how to assess the muscle strength. Zero, of course, there is no visible muscle contraction. One, there is only flicking contraction, but no movement. Two is joint movement only when gravity is eliminated. Ask the patient to lie down. If he is able to move like this, so now you can test when the gravity is eliminated. And grade 3 is movement against the gravity like this, but not against the examiner resistance. The grade 4, movement against resistance but weaker than normal, and grade 5 is normal. So this is how we test in different pictures showing against the resistance. If you are checking for the flexion, you ask the patient to you apply the resistance, ask the patient to flex it. The same thing, you if you want to do extension, you ask the patient to make a fist and put the pressure and ask him to extend. And same thing, apply a pressure and flex, like that you can do for different muscles. Coming to the reflexes, I'll discuss about deep tendon reflex and superficial reflex because they are more important. A reflex is an involuntary response to a sensory stimulus. Totally, you have 6 reflexes. Out of among them, deep tendon reflex, superficial, and plantar reflexes are important. The plantar, of course, is a part of superficial reflex only. So these are the reflexes. The way with the root value: biceps C5 C6, supinator C5 C6, triceps C8 T1. Some books also say C7. Knee is L3, L4, and ankle is S1, S2. So how to grade the reflexes? Grade 0 is loss, grade with absent, grade 1 is sluggish, grade 2 is normal, grade 3 hyper reflex, grade 4 is very brisk. Some books say grade 5 is brisk with clones. So this all I think everyone knows. Um, Coming to superficial reflexes and how to distinguish superficial reflex and dependent reflexes is that the superficial reflex involves the polysynaptic, it involves the multiple nerves, and dependent reflex usually is monosynaptic. And the superficial reflex undergoes fatigue easily, but if you do repeatedly, you may not be able to elicit the response. Whereas dependent reflexes repeatedly you can elicit. So the consistency is more with dependent reflexes, but less with superficial reflex. And more importantly, if there is a pyramidal tract involvement, it will abolish the superficial reflex. Whereas in pyramidal tract, the dependent reflexes will be brisk. The superficial reflex, what you test clinically is corneal nerve involvement. Corneal is just for both fifth and seventh nerve, where you bring the wisp of cotton from the sides and touch the is conjunctiva. So if it is intact, you will able to close the eyes. And coming to the abdominal reflexes, we have three: epigastric, mid-abdominal, and hypogastric. So you need to stroke from the lateral to the midline. If you stroke from the midline to lateral, you will not able to observe the movement of the umbilicus. It can lead you to wrong interpretations. The cremasteric reflex is usually carries a root value of L1, L2, where you stroke on the inner aspect of the thigh and there will be contraction of the scrotum. And similarly, inner reflex has a root value of S2, S3. If you stroke around the anus, there will be contraction of the anal muscles. The bulbocavernar reflex is how to do this is you wear a glove and insert a finger into the anal cavity. So this is same thing which I explained. Whenever we don't get a good response, we have is called gendristic manner. You ask the patient is to hold clasp like this and pull like this, or one punch in the teeth. So you can is done to increase the equipment of the impulses at the site. This is all what I explained already. So more important is plantar reflex. It is stroking the plantar surface of the foot from the heel forward up to the second metatarsal. Okay, when we stroke like it, usually normally we will have a plantar flexion of the toes and foot. The best position usually tested in the supine with knee extended and heel resting on the bed. Before doing the plantar response, just check the grade 2 movement. If there is an ankylosis, even if though if he has a positive, you may not able to elicit the response. So usually, particularly use the blunt key to elicit the response. So strength of stimulus from strong to minimal. See, sometimes if you have a classical pyramidal tract, even for minimal stimuli also, you can elicit the response. So normal response, normal position is there will be flexion of the great toes along with other toes. Abnormal response, what you call as Babinski sign, usually there will be great toe extensor and fanning out of other toes, and dorsiflexion of ankle, flexion at knee, and flexion at hip, and contraction of the tensor fasciolata together forms complete Babinski sign. How do you reinforce this is ask the while doing the test, you ask the patient to rotate the head to the opposite side for the better stimulus. Coming to the variants of the plantar response, usually we have three responses. One is equivocal. There will be a rapid extension and immediately followed by inflection, or there will be only grade 2 extension. There won't be other signs of like contraction of tensor, flata, and ankle movement will not be there. Or there will be an extension of the grade 2 with flexion of fingers and ankle and knee and tensor lesion functional component will be missing. So if anything is usually we will take it as a could be an onset of pyramidal tract lesions. The minimal plantar response is there is no toe movement, but there will be contraction of the tens fasciolata. Again, should be taken like that is involvement of pyramidal tract. The pseudobabelski is where the patient himself will be doing the extension of the grade toe because of the pain, or it because of some bony involvement where the thumb will be extended always. Coming to signs of cerebellum, to simply simplify what we do in the cerebellum examination is from head to toe. Their titubation will be there, where person will be nodding the head. Another thing, there will be an nystagmus. where we'll have a fast component and slow component. Usually, the fast component usually will be there towards the side of the lesion, and in the hands you will have an intention tremor. Like when he approaches an object, you will able to it will be very difficult to coordinate, and you will try to go for fast pointing, or you will overshoot the object. And again, you will test for Romberg sign, like where ask the patient to stand on the feet with eyes open, which also you will able to, you will have an giddiness or imbalance. That also goes in favor of cerebellar thing is. Another thing is we'll ask to do tandem walking, like where we'll ask the patient to do with heel and heel. So you're not able to do that. Ask the patient to walk along a straight line. That also you'll not able to do. That usually goes in favor of cerebellum. And also you will have a rebound phenomenon. So this is how we ask the patient to walk a straight line. If he has a cerebellar lesion, usually we will not able to do this. This is called tandem walking, that heel to toe walking. This also will not able to, because he can't coordinate. This is how you do finger, nose finger test. Usually, when ask him to touch your finger and then touch his nose, whenever the cerebellar lesion is there, you will not able to touch your nose, or you will not able to touch his nose properly because of the coordination. Usually, will overshoot. The same thing again. This is the what you call rebound phenomena. Ask the patient to stretch and you tap it. So if it is normal, it usually come back to the original position. It doesn't come back. It's nothing but cerebellar involvement is there. This is again heel to shin test. Ask the person to drag his feet from knees to ankle. Usually, because of the loss of the coordination, he will not able to do it. Coming to gait. So, how do you assess the gait? Is there a small pace? Is there? Yes. Then look at the posture. If it is stooped and no arm swing, it is also in favor of Parkinsonism. Posture is upright and arm swing is normal. It usually goes in favor of Marche Petimas. Small paces, no, and feet separation is there. And if there is a crossing over, it usually sees in seizure gait, that is paraplegic gait. If there is a wide base, then it could be two things. Then look for eye stepping. If the eye stepping is there, it goes in favor of peripheral neuropathy, that is sensory ataxia. If there is eye stepping is not there, but wide base is there, it goes in favor of cerebellar ataxia. Coming to the feet separation is normal, then look for eye stepping, then it usually goes in favor of bilateral foot drop. Eye stepping is not there, but pelvis is rotating, then it goes in favor of waddling gait. The pelvis rotating is not there, but movements are disjointed, then it goes in favor of apraxic gait. If there is no, then it could be a functional gait. This is again an example. So this is how the spastic gait, we'll call a circumduction gait, seizure gait, where there will be crossing over of the limbs. And coming to the propulsive gait or Parkinsonian gait, we call a stooped posture with reduced arm swing and short, small steps you will take. And waddling gait is usually seen in hip involvement. Nice stepper's gait usually seen where you will put like a stamp. You usually seen in peripheral neuropathy and cerebral lesion. Again, same thing. This is a classical presentation of festinate gait. The rigidity of the head and forward lift of the trunk, reduced arm swing, and short shuffling gait usually goes in for Parkinson's. Another example. This is a classical example of cerebellar gait, where you will have a wide-based gait as if like a center of the gravity. This is again seen in the paraparesis patient, where the limbs will cross over. This is seen in waddling gait. It's usually seen in hip lesions. Coming to the sensory system, the sensory system is carried by two tracts. One is posterior column, usually remains ipsilateral up to the medulla. After medulla, it crosses over, and spinothalamic tract usually crosses over immediately in the spinal cord itself after ascending one or two segments. So, coming to the modalities, the posterior column carries vibration and joint position sense. The light touch, temperature are carried by spinothalamic tract. So in the dorsal column, the posterior column usually cross over at the medulla and reach the opposite cortex. Whereas the latter spinothalamic tract carrying pain and temperature, immediately they cross over at the spinal cord after ascending two or three spinal segments. This is a representation how the fibers are represented in the spinal cord. The anteriorly you have a motor fibers that to more medially, that is anterior corticospinal tract, and in the posterior column is there in the dorsal column, and the spinal tract as they adjacent to the anterior corticospinal tract in the anterior portion of the spinal cord. So, sensations can be grossly divided into two things: the primary modality and secondary modality. The primary modalities are carried by the tracts which I mentioned. We will check touch, pressure, pain, and temperature, vibration. So, only if these things are intact, then you should go for cortical sensation. If these things are not intact, so you may not proceed to test these cortical sensation, as it may not able to, so it may not possible to elicit the response. So this is again, as I explained in Roman maximum representation is there for lip, thumb, and face. This I'll skip. So this how to check the pinprick sensation is: ask the patient to close the eyes. Always start from the distal. First, make the patient get accustomed to what you are doing. Test in the normal area. Ask the patient what he is feeling. Then you take this blunt end of the thing is, and start from the lower limb, then ascend upwards. Always test on the normal side, then test on the abnormal side, and ask the patient what is his response, whether it is zero, whether it is there is any some pain is appreciating or not, and ask him to grade it, whether it is mild, moderate, severe, like that. How do you check the temperature is, you take a test tube, in that you take a warm water, temperature of 40 to 45 degrees Celsius. Another bottle you can take it, temperature or water temperature carrying 5 to 10. If it is there beyond this, instead of temperature, you may be eliciting the pain response. Coming to how to touch is that touch is usually with a wisp of cotton. This is the examination of position signs. How do you test is, ask the patient to close his eyes and ask him to make a one sign. You make one sign in one hand. Ask the patient to repeat on other side. If you're not able to repeat that, then it goes in for dorsal column involvement. This is how you test the joint position test. First, you do it in the toes. Hold always in the sides, not in the anterior posterior direction. First, do with open eyes. Make the patient get accustomed with the movements. Make him accustomed what is up and down. So, if he's there not able to appreciate the direction of the movement, whether it is upward or downward, if he's not able to tell with the closed eyes more than 5 to 6 times, then it is taken as a positive. The same thing again, in a similar way, we'll do it in the upper limb also, where you hold the distal interphalangeal joint and move upward and backward. So again, coming to the tuning fork, the vibration sense. Usually we use 128 hertz uh, tuning fork because it has got longer decay compared to other tuning forks. First, you test him with the on that forehead and make him get accustomed to what is sensation you are testing, and ask you what he is able to feel. Then again, start from the lower limb and vibrate the tuning fork. Place it on the bony prominence like great toe, malleolus, and in the knees and in the hip like that, and in the upper limb, shut in the you check in the ribs, and then in the shoulder point, and then in the forehead. So how to approach is, first question you to ask is the distribution of a single nerve, then goes in favor of mononeuropathy. No, is the distribution of a single root, then it goes in for radiculopathy, where you will have radicular pain. If there is no distribution among the single root, then ask your question: is it affecting both the legs? If there is a clear cut upper level, then it goes in favor of spinal cord. If there is no clear cut upper limb, then it goes in favor of peripheral neuropathy. If it's not affecting both the limbs but affecting all the limbs, then ask your question whether it is limited to distal, that is glove and stocking. That usually goes in favor of diabetic neuropathy. If there is no glove stocking, distribution is not there, and if there is a clear cut upper level, then it goes in favor of cervical cord lesion, which can explain involvement of all the four limbs. Then ask a question: is there any sensory loss, including face? Then if it involves all the modalities, then it goes in favor of thalamic. If it's not so, then it goes in favor of internal capsule, where face will not be involved. Then hemisensory loss, no, but involvement of the contralateral face, then think of brainstem lesion. This is what I explained in the previous slide. So coming to the cortical sensation, what you test is 2-point discrimination. You take a compass, stimulate with the compass, you should able to see that there are two stimuli. So what is the shortest distance one can notify is 1 mm. It is usually happens in the tongue. Largest usually the wide gap at 30 to 40 mm is minimum is required for the back. Coming to the tactile localization, that if you stimulate any part of the body, patient should be able to tell which part of the body is stimulated. That is with closed eyes. All these are done with the closed eyes. The graphesthesia is ask the patient to close the eyes and draw a diagram on these hands, and you should be able to appreciate what you have drawn. Coming to the stereognosis, you ask the patient to close and give him a key or any familiar object, you should be able to tell that. Coming to the tactile extension, if you stimulate two different parts of the body, you should able to tell that you are stimulating the both the parts of the body. This is what I explained already. Coming to the science of meningeal, usually tested in meningitis, encephalitis kind of a thing. The next step is ask the patient to lie down and hold his neck and passively you try to flex. If you feel resistance, then next step is positive. Coming to the kerning sign and bowing sign, ask the patient to lie down, supine position, except knee, and you try to extend at the knee joint. If you feel stiffness and patient feels pain, then it means meningeal involvement is there. Same thing. So autonomic functions usually, like particular like in diabetes, chronic diabetes, usually it will be lost, or even in toxin something like lead. So what happens is when person stands from sitting to standing, there will be increase in heart rate and the blood pressure. Particularly blood pressure increases by 20 by 10. If it is not there, then it is called as posterior hypertension. Then it is called as positive. Coming to carotid massage, if you do the carotid massage, patient heart rate should fall because of the vagal nerve stimulus. Same thing happens with deep breathing and hyperventilation. And coming to the retention, is usually happens in the where patient will have not able to pass the urine. It happens in the upper motor. Incontinence is patient will have involuntary passage of the urine. It usually happens in lower motor is involvement and in autonomic nervous system pathologies. So summarize LMN and UMN. In higher mental function involvement is not be there in LMN, it will be there in UMN. The involvement of cranial nerves is not seen in LMN usually, but it happens in UMN, particularly in the brainstem. Superficial reflexes will be normal unless that segment is affected. It will be lost in UMN. And coming to the plantar, it will be flexor in LMN. It is extensor in UMN. And Babinski sign will be present in UMN. And reflexes will be brisk or excited. Sensory usually depends upon the nature of the fiber. Usually tingling and numbness. Tingling numbness goes in favor of large, and burning and absence of cold goes in favor of small fiber involvement. Another thing is again can be divided to positive and negative symptoms. Something like a burning and tingling goes in favor of positive symptoms. Absence of sensation, numbness goes in favor of negative symptoms. And usually in the UMN, sensory symptoms are seen only in spinal cord involvement. Coming to the bulk, as I explained, the atrophy is there in LMN, normal in UMN. The tone is hypertonia are normal in the LMN, exaggerated in the UMN. Power very much decreased in LMN, not that much decreased in UMN. And here individual mothers will be affected, and here group of affected. The gait patient usually will have a high stepping gait, and he will have a circumduction gait in UMN. The coordination is usually normal; it will be lost in UMN. So in the UMN, if there's involvement of the cortex, usually patient will have loss of consciousness and seizures. If there's a frontal lobe involvement, as I explained, you will have personality disinhibition and you will have motor aphasia. Parietal, if it is left side involvement, you will have difficulty in calculation. If it is the right side, approximate, where you will not able to do a skill task. It comes two things. The one is coronary radiata and thalamus and basal ganglia and internal capsule. So usually since the coronary area fibers are very much distributed, so you need a bigger lesion to cause maximal weakness. Whereas in internal capsule, all the fibers will be condensed. Even if it is small lesion, it can reach to dense if it is maximum weakness. The thalamus is called a sensory gate of man. So whenever the thalamus is there, there will be an hemisensory loss on the opposite side. And coming to the basal ganglia, which usually happens in Parkinsonism, patient will have tremor, rigidity, and postural instability and hyperkinetic movement will be there. The brainstem lesion, patient usually will have a vertigo and you will have a cross hemiplegia, that is ipsilateral cranial nerve involvement and contralateral hemiplegia. So this is what I told in cerebellar angina. They will have vertigo, giddiness, tremor, cross pointing, dysmetria, and rebound phenomena positive, and patient will not able to maintain the balance when with open eyes. So lower motor neuroimaging, it starts from the anterior. If there is involvement of anterior, usually happens in polio. It's usually pure motor, no sensory involvement. But if you have wasting, fasciculations will be there and reflex will be lost along the distribution. Radiculopathy, usually they will have radicular pain, asymmetric involvement will be there, but both sensory and motor will be there along the distribution of that radical, and there will be isolated reflex loss. So plexus, like it happens in brachial plexus, like C5, C6, and like that. So usually it will be asymmetrical loss. The proximal weakness will be more than distal weakness. They will have sensory and motor weakness. Coming to neuromuscular junction, usually happens in myasthenia gravis. They will have symmetrical weakness. Weakness more in end of the day, and both proximal and distal weakness will be there. There will be involvement of facial and ocular muscles, and there will be normal reflex, and they will have fatigue. So peripheral nerve, usually distal weakness is nerve, will have both sensory and motor. What I told, the glove and stalk distribution is usually happens in diabetes. It starts in the feet, then ascends the ankle and the knees. By the time it touches the knee, you will have involvement of the hands. That's why it's called glove and stalk distribution. Of course, they will have loss of reflexes, and depending upon the duration of illness, wasting can be there. The muscle usually will have proximal weakness. The how to distinguish proximal and distal weakness is if they has difficulty to squat, then is usually lower limb proximal weakness. If there's difficulty to grip the slippers, then it goes in favor of distal weakness. That is how to test. And in the upper limb, if there is a difficulty in mixing of the food, it is a distal weakness. If he has difficulty to comb, like which involves both proximal and distal weakness, lifting, then it goes in favor of proximal weakness. Usually, muscular involvement will be symmetrical. There will be no sensory, only pure motor is there and normal reflex. So this is a comprehensive of the nervous system. So it can be divided into pyramidal and extrapyramidal. Extrapyramidal is usually basal ganglia, happens in Parkinsonism, and pyramidal you get distinguished as UMN and LMN. In the UMN you have cortex, subcortex, brainstem, and spinal cord. And lower motor neuron, as I explained, anteancel, plexus, nerve, and neuromuscular junction and muscle. So come to the diagnosis, you'll write in the three components. The functional diagnosis can be an chemical diagnosis. You have to locate where damage is happened, which part of the nervous system. So for usual hemiplegia, it depends internal capsule, and paraplegia, spinal cord, and etiology, whether it is vascular or trauma. It will also can write which part of the artery is important. Thank you. What's it? No, 8 minutes. I don't know, sir. What is the rule of? No, I never often practice. I never visited the world. Usually, like you see, like whenever a patient comes to casualty or anything, you always check the plantar response. So if it is UMN, it will be extensor. Then again, you see, I told as a weakness. If it is a forelimbs, it has to be in cervical. If the conscious is gone, it has to be in the brainstem. It has to be only in the midline. Like that, we do it. I never heard of one session.
Good afternoon, sir. Sir, what is the role of first order neurons and second order neurons in the examination of nervous system, sir?
No, I think whatever there in the CNS in the cortex, it is called as first order neuron. Like that. So usually you don't classify any weakness like that in examination point of view. It's always you have to fix, like as I explained in the first chart, whether it is there in the muscle or in the neuromuscular junction, whether it is there in the nerve or in the plexus or in the spinal cord or in the brain. don't think that way you won't describe weakness any symptom in the in the
Sir,
examination part of it.
actually, as you said, in the upper motor neurons, brain and his spinal cord is involving, and lower motor neurons, all the periphery, uh, in the in the in the
I
facial
told
palsy.
UMN lesion, upper motor nerve
Yeah.
lesion and lower motor nerve lesion like that. So anything from the anterior on cell to the muscle, it is called as LMN. Anything from the spinal cord and above is UMN. Because if you elicit a plantar response, it has to be an extensor. If it is extensor, think from spinal cord and above. If it is in the spinal cord, conscious will be intact. You will not have seizure or any like memory disturbance will not be there. If it is there in the spinal cord, plantar will be extensor and definitely you will have sensory and motor and including bowel and bladder would have been affected. And again in the brainstem, in the brain, you come two things. Like one is cortex and another thing is basal ganglia. In the brainstem, usually you will have a cranial nerve involvement on the same side. Whereas in the cortex and internal capsule and above, you will not have cranial nerve involvement. You will have hemiplegia on one side. Along with it, we will have higher mental function getting affected, like memory, speech, seizures, and of course the weakness on the opposite side.
Thank you, sir.
Good afternoon, sir. As you explained that there is a clinical examination of clinical types of hemiplegia, contralateral and ipsilateral. So, what is complete and incomplete hemiplegia, and where should be the lesion?
See, complete means like that. See, whenever you have a stroke or a vascular event, like it takes time to completely. I'll explain in the initial only how it starts in the fingers, then it involves the shoulder like that. That is usually like you'll have weak see when you and affecting all the muscles of the that side, like one side, complete weakness is there
With face involvement.
with face involvement, depending upon the lesion where it is there in the brain.
And
You don't have any muscle movement on one side, that is the contralateral side of the lesion. Then it is called complete. Sometimes what happens is over a period of time he may improve, but you will not recover all the signs of weakness will not be recovered. Particularly like the fine movements will be lost. Complete means it is complete in all aspects. You don't have any movement, any remnant power, anything is not there. Incomplete usually happens in transient ischemic attack also.
Thank you, sir. I now call upon Professor Abid Ali Ansari, HOD Department of Mythol Amraze, to kindly give a memento to Dr. Bhimarayadi. Thank you, sir. Moving on with today's program, I would like to call upon Professor Arshia Sultana, to give a talk on brain and baby navigating neurological disorders during pregnancy. Dr. Arshia Sultana conferences and workshop. She is an advisory member board, editorial board member, and reviewer in various national and international journals. Over to you, madam.
Hello, Assalamu alaikum. At the outside, I'd like to thank Director in charge for giving this opportunity to keep the conference. And here we are going for interdisciplinary approach. Maybe the topic is different for you people because we are going to speak about brain and baby, navigating neurological disorders during pregnancy. So that's it. The introduction is, outline is introduction, contemporary classification of neurological disorders, neurological diseases during pregnancy and its classification in conventional medicine. Let us start the introduction. So today, as we all know, we have gathered for CNS. So you know what is the definition? That neurological disorders affects the brain as well as the nerves found throughout the human body and spinal cord. What happens in neurological disorder is we see that there is structural, biochemical and electrical abnormalities in the brain, spinal cord or other nerves that can result in range of symptoms. What are the symptoms? It can be paralysis, muscle weakness, poor coordination, loss of sensation, convulsions, confusion, pain and altered sensorium or altered conscious. Then, according to Unani system of medicine, already Dr. Muzaffarpur has explained you about nervous system in Unani system. I'm not going in detail. Just for updation, we know that in Unani it has been classified that Aza and Afsaniac is brain, spinal cord, and sense organs. When we see the diseases which occur in brain are, it can be headache, epilepsy, it can be meningitis. When it comes to spinal cord, the diseases can be paralysis, weakness, tashanuj, and paresthesia. So here, when we classify the nervous system, we see that nervous system can be divided into central nervous system and peripheral nervous system. Central nervous system, again, it includes brain and spinal cord, whereas peripheral system includes motor and sensory neurons. Motor neuron, again, somatic, autonomous, sympathetic, and parasympathetic. So it's a just revision for the students. Then, when we come to neurological disorders, we can see that the disorders which occur in brain, the same disorders can also occur in the pregnant woman. What we see in the general population, the same can be seen in pregnancy also. So what are the diseases? It can be tumors, seizures, genetic disorders, degenerative disorders, cerebral vascular accidents, and neurological infections. So any of these can occur during pregnancy also. So now let me come to my own topic, that is pregnancy and neurological disorders. We all know that pregnancy is a unique period of life where significant hormonal and other physiological changes occurs in female, which may trigger or alter the course of medical conditions, including neurological disorders. What happens because of neurological disorder? All their treatment. Because when we give treatment of epilepsy, it can affect pregnancy. So we see that it has significant negative effect on pregnancy, labor or delivery. Now you can see that because of neurological disorders, especially neurovascular disorders, we can see that maternal mortality is seen in 7% of which causes 7% of maternal death. So it is very high. The maternal mortality, that is maternal death, it can be around 7%, and we see that the psychiatric disorder also play a role in the neurological disorders. Therefore, when you're seeing any nervous system or any neurological diseases, we have to keep in mind about psychiatric disorders also when you're evaluating the case. So here, when we say neurological disorder, just now I said that any disease can occur which occurs in the general population. We can again divide the diseases into central and peripheral. The central diseases which can occur in the pregnant woman is headache, migraine, which can be seen in general population also. And we see cerebrovascular complications like cerebral vascular thrombosis, atriovenous malformation, aneurysm, rupture, and subarachnoid hemorrhages. And when we see peripheral, it can be carpal tunnel syndrome or Bell's palsy. So here we can see that the peripheral disorders like carpal tunnel syndrome and Bell's palsy is usually seen in third trimester. That is in last trimester, Whereas we can see that atrial malformation can be seen in the first trimester and migraine without aura can be seen in the first trimester. So we see that the distribution of diseases differs according to the trimesters also. Then, as we said, nevertheless, the range of neurological conditions affecting women of reproductive age is extremely broad. Why? Because we see that there are some neurological diseases which manifest only during pregnancy, or because of pregnancy, they may cause neurological disorders. For example, preeclampsia, eclampsia, acute fatty liver of pregnancy, and amniotic fluid embolism. These diseases, which are pertaining to obstetric illness, can lead to neurological disorders. Then other, although indirectly related to pregnancy, such as cerebral venous thrombosis, ischemic stroke, and intracerebral hemorrhage, increase in frequency and carry considerable risk of morbidity and mortality. That's why here I'm not going to say anything about treatment. Just I'm going to say about the etiology which can cause neurological disorders during pregnancy. So here we can see that just now I said you there are some unique diseases which occurs in pregnancy which can lead to neurological diseases. For example, preeclampsia. Some are unique to pregnant postpartum state, including preeclampsia and delivery-associated neuropathies. We said that carpal tunnel syndrome can occur in pregnancy, but it is not exclusively seen in pregnancy. And most important, the diagnosis of neurological disorders during pregnancy is always a challenging task. Why? Because symptomology may vary due to hormonal changes and exaggerated physiological responses during pregnancy. I'm audible to all? Then I said you that neurological diseases in pregnancy can be pre-existing, for example, a general population. Okay. So here we can see that the pre-existing diseases which can be present in a person or woman, she may become pregnant. For example, epilepsy, woman may be having epilepsy or she may become pregnant. So these are the pre-existing diseases which can be seen in a woman: epilepsy, migraine, myasthenia gravis, multiple sclerosis, where the patient can become pregnant. And the new onset disorders are because of pregnancy: preeclampsia, eclampsia, cerebral venous thrombosis, cerebral hemorrhage, compression and stretch. These are the new onset which can lead to neurological disorders. So here in one of the paper, it is said in 2022 that maternal complications in women with pre-existing neurological condition may have higher risk of experiencing severe maternal morbidity at the time of delivery and being readmitted within 30 and 90 days. So we can see that these are the pre-existing diseases which can be seen during in a woman, and the woman can become pregnant. That is stroke, migraine, myasthenia gravis, and multiple sclerosis. So now we are saying that the pre-existing disorders like epilepsy, the girl may have or the woman may have epilepsy since childhood. In them, if they become pregnant, 1/3 of the pregnant women, the epilepsy may be worsened and they may have seizures during labor. Same like that, changes in hemodynamics and blood volume and hormonal effect on the vessel wall increase the risk of bleeding from aneurysm and atriovenous malformation during pregnancy and postpartum period. Therefore, it is important for the doctors to know what are the pre-existing diseases in a woman, because suppose if the woman becomes pregnant with epilepsy, then the drug can also cause symptoms or syndromes. Pregnancy and the postpartum period are associated with marked increase in the relative risk and small increase in the absolute risk of stroke. So stroke is also more common during pregnancy. Then there is a study conducted in 2017, from 2016 to 2017, where 4,200 patients were registered for the study, and neurological disorders were present in 344 patients, that is 4.28%. That means we can see that neurological disorders can occur in 4.8% of women. Then we can see that headache is a common neurological disorders seen in women, followed by seizures. Then there is one more study carried in 2006, which showed that the primary neurological disorders can be seen in 60.5% and secondary neurological disorders can be seen in 39.5%. And we can see that epilepsy was more common primary neurological disorder seen in the pregnant women. Then again, other studies have compared what are the neurological disorders seen during pregnancy, and we can see that first two studies showed that epilepsy is more common, whereas we can see that in this study, eclampsia was also common, and this study said that cerebrovascular disorders are more common. And Agarwal and Srinivasan also said that cerebrovascular disorders are more common during pregnancy. In this study also we can see that epilepsy is a common disorder seen during pregnancy. Then what are the neurological manifestations and diseases seen in pregnancy? So we can see that headache, seizures, cerebrovascular diseases, demyelinating or degenerative disorders, neuropathies and spinal cord injuries are common during pregnancy. So headache, we all know what is headache. It is extremely common problem seen both during and outside the pregnancy and requires structured approach. And according to Unani system of medicine also, excessive postmortem hemorrhage, puerperal sepsis and post-abortal sepsis can cause headache. We can see that 99% of women will experience some degree of headache at some time during 9 months, long duration of pregnancy and during puerperium. In them, 1/3 is seen in mid-trimester, and we see that 97% of headache are benign in nature and only 5% of headache is serious, which can cause complications of sequelae. And we can see that in 2/3 patients, it will be more common as migraine, and the 1/3 will have tension headache. So we all know what is the pathophysiology of headache. I'm not going in detail. Then headache may result from direct stimulation causing direct pain. So directly it can cause pain, or secondary inflammatory effects of vasoactive neuropeptides released after stimulation of the sensory fibers can also cause headache. So headache can be direct or it can be because of inflammatory processes. Then not only that, we see that sex hormones, particularly estrogen, influence the system directly or indirectly, directly or directly modifies the cerebral blood flow or neuropeptides. So we see that the sex hormone, that is mainly estrogen, can have an effect on neurological disorder. Because of this complicated interaction, there are many variables and potential points for intervention for the treatment. Then, as I said you, headaches can be primary, it can be secondary. Primary headaches can be migraine, tension headache, cluster headache. Primary headaches can be associated with some diseases like fever, cough, exhaustion, and sinusitis, whereas secondary headaches can be because of injuries, vascular disorders, non-vascular intracranial disorders, drug withdrawal, disorders of homeostasis, disorders of cranial structures, and neuralgia. So we have to first distinguish the pregnant woman is having primary headache or secondary headache. Migraine headaches are type of vascular headache. I don't have to go in detail, you all know. And they are different from stress or tension headaches, and we know how it occurs. Next, after seeing headaches, as we saw that headache is common in 99% of women during pregnancy, but we have to differentiate that the 5% women may have complications because of headache. Because of that 5%, we have to know what is headache. Then next is seizures disorders. We can see that seizures are caused by abnormal electrical activities in the brain, which is seen with or without loss of consciousness. So again, we just now saw that epilepsy can be pre-existing and the woman can become pregnant. So what will happen? We can see that the commonest cause of seizures during pregnancy is pre-existing epilepsy. Just now we saw the studies that epilepsy is more common neurological disorders. New onset seizures with normal BP we have to exclude. Cerebral parenchymal disorders and metabolic dearrangements such as hyponatremia and hypoglycemia. And the presence of hypertension always points towards eclampsia or pre-eclampsia. Next, we have to remember that fulminant hepatic failure due to acute fatty liver of pregnancy or acute viral hepatitis may also cause convulsions. So whenever the pregnant woman comes with seizures or convulsion, don't think it may be epilepsy only. Don't think it may be pre-eclampsia or eclampsia only. It can be hepatic failure also, which may cause seizures or coma. Then we know that epilepsy, it is estimated that 7% of epileptic patients become pregnant, in which 0.5% of pregnant women or complicated by epilepsy, and status epilepticus is associated with high maternal as well as fetal mortality. Then Unani, sometimes according to Unani book, it is said that sometimes in female and lactating women, Prashanus is seen because of accumulation of Madhya Ratha in Asap and avatar of breast. And sometimes pregnant women may have Prashan. So our textbook has said that pregnant women may have neurological disorders. Then accumulation of menstrual blood when gets mutafin or during pregnancy, amenorrhea can cause Pokhara to ascend to the Dimagh, leading to epilepsy. Hence, epilepsy can occur during pregnancy and cured after delivery, as far as fast hormone producing Bukharat is eliminated from the body after parturition. So, what is the book saying? According to our literature, that the woman may develop convulsions or seizures during pregnancy and it may get subsided after purpuring. Most probably, they wanted to say that the convulsions may be because of eclampsia also. Because they are saying it disappears after the patient is in after parturition. That shows that they were aware of eclamptic fits also. But that time eclampsia was not known. That's why they have labeled it as epilepsy. Then any substance or matter which causes tashannuj or ziyad dimagh leads to disturbance of pathway of Roux and results in epilepsy. Unani scholars also said that involvement of other organs such as liver, spleen, uterus causes Sayashaki. That means just now we saw that pulmonary hepatic failure can lead to convulsions or seizures. Then what are the maternal effects of epilepsy? It can cause lactic acidosis, increased cardiac output, transient elevation of blood pressure, increased intra-abdominal pressure, redistribution of blood flow to the brain and muscles with consequent decrease in visceral and uterine flow. So these are the maternal effects of epilepsy on the woman. So, risk of seizures during labor is 9 times greater than during the rest of pregnancy. So, we see that seizures are more common during intrapartum period or labor. Then we can see what is the fetal effect of epilepsy. It can cause stillbirth, prematurity, perinatal death, congenital anomalies, and hemorrhagic diseases of newborn and intracranial hemorrhage. So, we see that if a woman has epilepsy, it becomes a high risk case. In these cases, we have to go for multidisciplinary approach to prevent fetal effects of epilepsy. Then, in a study, they showed that women with epilepsy have increased incidence of hyperemesis gravidarum, preeclampsia, premature labor, instrumental deliveries, and cesarean section. Then next comes preeclampsia, where we can see convulsions or seizures. That epilepsy is a pre-existing disease, but we see that eclampsia or preeclampsia is a new onset neurological disease which is only seen during pregnancy. Preeclampsia is a complex disorder with pregnancy-induced hypertension developing after 20 weeks of gestation. We know that the symptoms of preeclampsia are swelling, protein in urea, and arterial hypertension. So, when the woman is having preeclampsia and she develops seizures, then we call it as eclampsia. So, eclampsia is a life-threatening complication of gestational hypertension with high maternal and perinatal mortality. Here, you can see that eclampsia is focal, motor, or generalized tonic-clonic, usually appearing within first 24 hours postpartum. Then we can see what is the exact cause of convulsions. We don't know, but the underlying cause for preeclampsia and eclampsia remains unknown, but abnormal immunological interaction between fetal and maternal tissues are involved. So we see that in eclampsia, the woman will develop cerebral edema, headache, convulsions, and visual disturbances. And again, we can see that HELP syndrome can also cause eclamptic fits, and therefore we should be well aware about preeclampsia and eclampsia. Third disease is cerebrovascular disease. How many diseases we have seen till now? How many? Headache and seizures. Now the third is cerebrovascular diseases. So when we say cerebrovascular diseases, first one is paralysis of knowledge. We can see that Unani scholars said that it can occur during pregnancy. So paralysis can be seen during pregnancy, and we see that they also said that in postpartum period, because if a woman use mubarak, ashya or cold items, she may develop paralysis. They also said that stroke occurs because of both ischemic and hemorrhagic causes. So the cause of paralysis is same what we see in general population, that is ischemia and hemorrhage. Stroke a major contributor to morbidity and mortality during pregnancy and period. So next, ischemic strokes, we can see that 3.5 to 5 per 1 lakh pregnancy women can have ischemic stroke during pregnancy. So the incidence is 3.5 to 5 per 1 lakh. And we see majority of the women will develop ischemic stroke in late pregnancy, particularly in postpartum period. Then stroke in young group of 12% to 35%. And what is the mechanism of pregnancy associated stroke is women may have hypertension or eclampsia or preeclampsia or pre-existing hypertension, or there can be intracranial venous diseases which can lead to stroke, or there can be extracranial or intracranial atrial diseases, aneurysm or cardioembolic, like for example valvular heart disease, atrial fibrillation, peripartum cardiomyopathy, or can also cause stroke during pregnancy. Then both transient and ischemic attack and ischemic stroke occurs 5 to 10 times more common during pregnancy and postpartum. That means we have to remember that there is risk of 5 to 10 times. The risk is probably highest in the first week postpartum. So we have to be very vigilant if the woman is developing any complications during postpartum period. Why the stroke occurs in late trimesters or in postpartum period means the hypercoagulable disorders are concerned for stroke in young and can be related to both venous and atrial thrombosis. So stroke is more common in late trimester and postpartum because of hypercoagulable state of the pregnant woman. Preeclampsia is associated with fold increase in stroke during pregnancy. That's why if a woman is having hypertension, she is a high-risk case. We cannot neglect that woman because she may develop mortalities like stroke, HELP syndrome. So we have to be very vigilant when we are treating a patient of hypertension with pregnancy. Then the risk factors according to Unani which can cause paralysis, old age, cold weather, intolerance, sway mismatch, lakwa, trauma, pregnancy and balgam producing food. This leads to Suddha formation is A'sab and Butune Dimagh which can cause paralysis. So here we can see the pathophysiology of stroke, physiologic and hemodynamic changes in pregnancy because of hypercoagulability, increased cardiac burden, altered vascular tone, which can cause stroke. This all things are because there is a physiological demand of growing fetus and reduced hemorrhage during delivery. So hypercoagulability promotes development of venous thromboemboli in an individual. Next, in cerebrovascular, we can see cerebral venous thrombosis. It is also 12% common during pregnancy, and we can see that there is 120% to 300% increase in circulating levels of coagulating factors during pregnancy, which can cause cerebrovenous thrombosis. So the level of protein S is decreased, but that of protein C remains unchanged. Protein C and protein S are nothing but they are anticoagulant proteins which prevent hypercoagulability. So we see that the C remains unchanged. There is decrease in S protein which causes hypercoagulability of the blood leading to cerebrovascular thrombosis. Headache is the commonest symptom of cerebrovascular thrombosis and occurs in 95% patients. So you have to be very, because I said you 95% the headache is benign, but in 5% it can be because of some disease, and the most common symptom of CVT is headache. Other manifestations are seizures, paralysis, papilledema, altered consciousness, and isolated intracranial hypertension. So don't think if a woman comes to you with hypertension, it is only because of pregnancy. It can be because of CVT also. So you have to differentially diagnose that the woman who is developing hypertension, is it due to pregnancy or it is due to other diseases. Next, posterior reversible encephalopathy. Again, this is a rare condition which can occur during pregnancy. It involves neurotoxic state, most often characterized by headache, altered mental status, visual impairment, and seizures. Then, last, intracerebral hemorrhages. We can see it is though rare, but the mortality is 40 to 50% women. If suppose the woman develops intracerebral hemorrhage, 40 to 50% women will die because of it. When we say maternal mortality, it means The woman may die because of intracranial hemorrhages. The differential diagnosis of venous infarction or hemorrhagic transformation of arterial infarction. What are the causes for intracerebral hemorrhages? Hypertension, atriovenous malformation, anticoagulation treatment, bleeding disorders, and brain tumors. So, if a woman has intracerebral hemorrhage, the causes should be here. First is what? Hypertension. So, you have to remember hypertension, if a woman develops, you have to be very, very careful. Don't think nothing will happen. Anything can happen because it can lead to neurological sequelae or complications. Next, demyelinating or degenerative diseases. So we are only going to discuss about multiple sclerosis, which can be seen during pregnancy. We know what is multiple sclerosis. I'm not going here. The woman may have neuroinflammation and neurodegeneration. Multiple sclerosis is usually diagnosed between 20 and 50 years old, and so women with MS will therefore become pregnant relatively earlier in the course of their illnesses and usually have correspondingly little associated disability. So what is the pathological changes? There is loss of myelin sheath. This is autoimmune disease, release of pro-inflammatory mediators which will cause neuroinflammation and disrupt synaptic glutamate causing excitotoxicity. So we can see these are the symptoms which can be seen in multiple sclerosis. If woman complains numbness or pain, don't take it easy. We may think it's because of vitamin B complex deficiency. We may think it's because of pregnancy, but it can be because of multiple sclerosis also. You have to go for differential diagnosis when you are seeing a pregnant woman. Cranial and peripheral neuropathies. So again, we can see acute onset of muscle weakness may result from spinal cord, peripheral nerve, or neuromuscular junction disorders. Spinal cord involvement due to trauma or demyelination may occur. Peripheral neuropathy due to GB syndrome or porphyria may occur, and some patients may experience a worsening of myasthenia gravis during pregnancy. So most important disease which we have to discuss during pregnancy is myasthenia gravis. It is autoimmune neuromuscular disease characterized by weakness and fatigue of skeletal muscles of face and extremities. It is important to remember this point. If a woman comes with history of myasthenia gravis, it is advisable to delay pregnancy for at least 2 years following diagnosis as mortality is highest. So this point is very important for a practitioner to remember that a woman comes with myasthenia gravis, she has to delay her pregnancy. Severity of symptoms and risk of maternal mortality is lowest 7 years after the onset of disease. If a woman is having chronic myasthenia gravis, the chances of decreasing mortality is more. Exacerbation of symptoms are more likely to occur in the first trimester of following delivery. What is the effect? We can see it can cause transient neonatal myasthenia gravis in 10 to 20% of child, and the neonate typically develops symptoms 2 to 4 days after birth, including respiratory problems, muscle weakness, feeble cry, poor sucking, and ptosis. First, Bell's palsy, idiopathic facial nerve palsy can occur during pregnancy, and we see the annual incidence is 17 per 1 lakh in women. When facial nerve palsy is associated with pregnancy, 75% cases are seen in third trimester. That means Bell's palsy is more common in third trimester. Here we can see that the prognosis of recovery is very good in Bell's palsy. In 10 days, course of steroid of 40 mg to 60 mg is safe during pregnancy. So, if a woman develops Bell's palsy, usually the neurologist advises steroids. So, intracranial neoplasms, you can see there are different neoplasms or tumors occurring during pregnancy. Like glycomas are the commonest tumor in pregnant patients and account for 38% of all primary brain tumors, followed by meningiomas and acoustic neuromas. Most brain tumors expand considerably during pregnancy and often manifest for the first time in pregnant patients. So I have seen a case like this. She was pregnant around 36 weeks with brain tumor. She was having complete blindness. So she was operated by LSCA to go for brain surgery. So risk factors: there is increased risk of stroke, seizures, and other complications. Potential for fetal growth restriction and preterm labor. Risk of maternal mortality and morbidity, and impact mental health and quality of life. So what are the challenges? It is challenge to distinguish between symptoms of neurological diseases and normal pregnancy symptoms. We have limited availability of pregnancy-specific treatment guidelines For neurological disorders, concerned about medication safety and efficacy during pregnancy because we know that epileptic drug can cause syndromes. Concerned about medication safety and efficacy during pregnancy, therefore we need a multidisciplinary care team for this. Opportunities, we should increase awareness and education among healthcare providers and patients, development of pregnancy-specific treatment guidelines and protocols, advancement in diagnostic techniques and imaging modalities, and improved multidisciplinary care and coordination is required to improve care of neurological disorders during pregnancy. So conclusion, neurological disease presents a particular challenge to those providing obstetric care to minimize maternal, fetal and neonatal morbidity. Any woman of childbearing age with a neurological condition must receive appropriate pre-pregnancy counseling because if the woman is on anticonvulsant, she needs pre-conceptual counseling to change the drug. If she is having any cerebrovascular thrombosis pre-existing or she is having migraine, so we have to pre-pregnancy counseling is needed in the woman to change the drug. Literature exploration of various Unani classical texts reveal that epilepsy can occur during pregnancy. Headache occurs due to excessive postpartum hemorrhage, puerperal sepsis, and post-abortal sepsis. Sometimes in female and lactating women, Tashanush is observed. In postpartum period, use of Mubarak Ashia can also lead to fallage. During pregnancy, they are managed by experienced multidisciplinary team, including a neurologist, specialist nurse or midwife, maternal medicine, obstetrician and obstetric physician and obstetric anesthetist. With this, thank you.
Thank you, Dr. Arshia, for your enlightened speech. Audience, any questions?
I think so many of the UG scholars have not understood anything. Any doubts?
I now call upon Professor Isma Shamim, HOD Department of Amraze Nizban Waq Babalat, to kindly hand over the certificate to Professor Arshia Sultana. We now take a break for lunch. We'll assemble back for our part 2 session at 2 o'clock. We have 3 scientific sessions in the afternoon. Kindly get back in the audience by 2 o'clock. Thank you.
We have 3 lectures in the afternoon, one from the faculty of Unani, one from Ayurveda and one from Homeopathy. Hope you all join with a vigorous attention. Do not feel gloomy. After the lunch, please join us at 2.
And please use dustbins. Okay? We are following Swachh Bharat Abhiyan. Okay? Thank you.